Welcome to the Unity Forum, a cross-partisan program dedicated to fostering reasoned discourse and a more open society. In each episode, we talk with well-established experts to provide insight on recent events, elevate civil dialogue, and encourage greater mutual understanding on social, economic, and legal issues. Our host is Chris Malone, founder of Fidelum Group and author of the award-winning book, The Human Brand: How We Relate to People, Products, and Companies.
Welcome and hello. I'm Chris Malone and I'll be your host for today's discussion. Thank you for joining us. Before we begin, I'm delighted to welcome a special co-host for today's program, Terry Akin. Terry is the former CEO of Cone Health, where he led a nationally recognized not-for-profit healthcare system committed to patient-centered care and community health improvement. Throughout his career, Terry has been a champion of values-driven leadership, implementation of value-based care models, and transformative innovation in healthcare delivery. I'm grateful to have him join us for today's discussion. Welcome, Terry. What can you tell us about our guest today?
Thank you, Chris. It's good to be with everyone today. I'm excited to introduce someone who has been a source of real inspiration for much of my own work over the years. Our guest today is Dr. Don Berwick. Dr. Berwick is one of America's leading voices on healthcare quality, safety, and reform, a former administrator of the Centers for Medicare and Medicaid Services, and the founding president and CEO of the Institute for Healthcare Improvement. Dr. Berwick has devoted more than 3 decades to transforming how health systems deliver care. He began his career as a pediatrician and clinician, and later served on the faculty of both Harvard Medical School and the Harvard T.H. Chan School of Public Health. His work spans national policy leadership, groundbreaking campaigns like the 100,000 Lives Initiative, and global efforts to improve patient outcomes. Among his many recognitions are the Heinz Award for Public Policy, an honorary knighthood from the United Kingdom, and election to the National Academy of Medicine. Throughout his career, Dr. Berwick has emphasized not only technical and clinical excellence in healthcare, but the moral and human dimensions of caregiving, arguing that trust, dignity, and compassion are essential to building a sustainable system. Welcome to the Unity Forum, Dr. Berwick.
Thank you, Terry, and thank you, Chris. And Terry, let me offer you my congratulations on your leadership at Cone. It really was a place to watch. It's a pleasure to get to work with you.
Thank you.
Chris, thanks for inviting me.
Glad to have you. So Don, let's start with the big picture. There are a lot of significant changes underway in the U.S. healthcare system right now. In your view, what are the most urgent changes that we should be focusing on, whether we're a patient, family, healthcare professional? What should we be paying attention to?
Well, as voters and stewards of our country, I think we all have to be paying attention to the, in my opinion, quite negative policies that are emerging in the federal landscape. What I lose sleep at night is the cutbacks in Medicaid that are about to hit, the insertion of work requirements and onerous re-enrollment barriers are going to reduce the number of Medicaid patients who are entitled to Medicaid, but who actually sign up for it. That's going to leave a lot of people uninsured, in the millions. We don't know how many million, but overall, probably 2 to 4 million Medicaid patients. In addition, the end of the premium tax credits for purchasing healthcare premiums, healthcare insurance on the exchanges is going to leave another 8 or 10 million people without coverage. In other words, we're going to have a very serious coverage decrease. Some of that will be mediated with increases in premiums, big ones. And so to the people listening, patients, families, healthcare professionals, we're going to have to understand that healthcare premium is going to rise and people are going to be uninsured, and we need to engage in local and hopefully state level initiatives to provide coverage. I'm personally concerned about the attacks on science, and both in NIH and more, maybe to listeners more pertinently, CDC. CDC was the envy of the world in leading us to understand what proper preventive practices are. Now that leadership has been lost, CDC has been cut back to the bone. For patients and families, you're going to have to find another way to learn, another source of reliable information about the preventive practices and vaccinations that you should be engaging in, because CDC is no longer a reliable source for that guidance. The attack on science means that there'll be efforts to decrease your trust in what science knows. Science is a continually evolving enterprise. By definition, it keeps finding out the next thing it needs to know, and maybe past things were wrong. You're going to have to be a sophisticated consumer of science, again, from sources other than the traditional federal government sources. Finally, if some of the initiatives for coverage that are coming forward are to advance so-called health savings accounts, where you'll be allowed tax-free to put money into the pot. You will notice that the amount of money you're allowed to use to put into a health savings account is nowhere near what you're going to need if you get sick. And so don't get fooled. You're still going to have to engage in prudent practices to be able to afford care. I guess the other thing is maybe science-based prevention has never been more important, because if you become sick, it's going to cost you a ton more. And this is a time to get serious about, as we should have been all along, and preserving your own health and those of your children and the elders who depend on you.
So we just covered a whole bunch right there. Let's kind of unpack, each of those a little bit further at a time. Terry, you want to dig into Affordable Care Act issues with Don?
Sure. So, Don, it now seems that the need-based subsidies for the Affordable Care Act insurance plans will expire at the end of December. And as I was telling you beforehand, this is up close and personal for my family. I'm no longer receiving employer-provided health care, and I'm just short of Medicare age. And so we're going to see our premiums triple this year. So one data point. What do you expect this will look like overall in terms of reductions in coverage, access, and care in general as it ripples across the U.S. healthcare system?
Well, I'm sorry for the challenges that you and so many people are facing with healthcare premium costs, Harry. I can't resist pointing out that if Medicare were available to you now, or to everyone, you wouldn't be facing that problem. The government insurance program generally has been a very good one. The effects are hardly a ripple. It's really a big wave. So let me explain the premium tax credits, just for people that haven't kept up with this arcane field. When the Affordable Care Act was passed, an element of it was to expand Medicaid, which we can talk about, but a really important part was to set up exchanges in which people who didn't otherwise have access to health insurance could buy health insurance. Now, most people really in the workforce couldn't afford to do that. They need some subsidies. In the original Affordable Care Act, those subsidies went up to about 400% of the federal poverty line, so you could afford to buy health insurance with this premium tax credit. When the COVID hit, that credit was extended into enhanced premium tax credit, which allowed more people access to affordable insurance. To give you an idea of the challenge, I was just working with the state of Vermont, where now I believe this is true. I'm not totally sure, but I think it's close. The premium for a family of four is now $50,000 a year. So you don't have to be very poor in order to not be able to afford that. These enhanced premium tax credits do put premiums in reach financially for families at that level of $100,000 a year income. Now they're going to go away. Congress has been unable to come up with an agreement to extend them. That means millions of people in this country are going to be seeing sudden and very severe increases in their premiums. The insurance companies that offer those premiums really have no choice but to raise premiums, because it's a vicious cycle. If the premiums start to go up because the tax credits are gone, then healthy people stay out of the insurance system, leaving the residual people are sicker. So there's a vicious cycle. As the sicker people stay in the insurance program, the actuarial risk goes up for the insurance company. They have to raise premiums to cover that, which again drives more well people out of the system. You end up with this cycle where the people who stay in the system have much higher premiums. That's at the individual level. Then you have to look at the institutional level. So what happens downstream? Downstream, hospitals now will be seeing patients who don't have coverage. And that's going to increase their costs. And to the extent they can be rescued, that'll be rescued by states and cities whose costs will go up. which means the other things that states and cities provide, education, roads, recreational opportunities, will have their budgets even more strapped, as well as small hospitals and rural hospitals that don't have enough money already will have even less. So as a citizen, you will see a decrease in the flexibility that cities and states have to invest in things you care about. And the local hospital may suddenly be able to have to cut back on services that it offers, and may even, in some, the worst cases, close. So that's the rippling of this increase in health insurance through your life, and not just in healthcare. I could go on, but I'd create even more depression if I did that. So maybe I should stop for a minute.
Thank you. So let's dig into the Medicare side of it a little bit more, particularly as it relates to how this is going to impact healthcare organizations and professionals. I suspect that it won't be just those who are not going to receive Medicare or Medicaid benefits that will be impacted, that there will be an impact on the healthcare provider and professional side as well. What are your thoughts on that? What do you expect that impact to be?
Well, your hospital will be getting paid less. It'll have less money, which means services you may depend on will be less available to you because the hospital can't afford to keep them going, whether you're on Medicare or not. Medicare is a great program which entitles you to insurance that is the envy of many other Americans, but that doesn't mean the services can be there if they're not being paid for. Which services are less protected? Well, the ones that are less urgent. Emergency care has to be given, emergency surgery has to be done, but elective things and the other sources of care, especially mental health care and primary care, you may find under increased stress. You're probably already having trouble reaching your doctor. I suspect that'll get worse. And by the way, as the system is pressured, the pressure settles in on doctors and nurses who are already a very stressed part of our workforce. We have shortages, especially in primary care now. We have increasing number of doctors leaving the field. We have hundreds of thousands of nurse shortages now in the country. And one would expect as this pressures increase, more people will decide maybe it's time to retire or to find a different place to give care. Quality of care is an issue because your doctor, your nurse, they want to give you high quality care. They're not there to do you harm. But as they get stressed, the amount of attention they have to devote to making sure you're safe in care or that they can be truly complete in their diagnostic and therapeutic work, well, that decreases. And so I fear that even independent of the damage being done through the cutbacks in the CDC and NIH, we're going to see this ripple through in at least less access, and I think threats to quality. We already know that patient safety goes down when nurses are under a lot of stress. I mean, they're human beings, and they start to forget things. Or doctors who are tired will be less likely to be thorough. So it's not a good scene in terms of the healthcare workforce and how they can take care of you. I'm more worried about Medicaid than Medicare now, I must say. There are certain legal restrictions on Medicare cutbacks. It can't be the deep pockets that fund other things according to law. Medicaid is much more vulnerable, but as we said earlier, as Medicaid gets cut back, the effects do ripple through the entire healthcare system. Is that what you were asking, Chris? Did I answer your question?
Yeah, absolutely. And I hate to, perhaps overstate the situation, but because it's so fresh in our mind from just a few years ago, I fear that some of the same type of dynamics that we observed in the pandemic could start to, have some impact at some level. Deferral of care, deferral of diagnosis, increased strain, all of those things. And not to suggest this would be at that level, obviously, but, those are fresh in our minds and, worrisome concerns, I think, as we can think about how healthcare providers will be impacted.
I think it could approach that level, especially in communities that are already somewhat underserved, such as safety net communities and rural communities, especially, which they just don't have the resilience in their healthcare systems to deal with some of these issues. I'm sure Terry has views of this from his long experience at Cone Health. So there's a lot of vulnerability here, and I think your thought that this could feel a little bit like back in those terrible pandemic days is not too far off the mark. The other thing that will happen is the private sector will step up. My wife and I, in our year-end contributions, are already trying to give more money to food banks and social services in the towns that serve us. They're going to be under more stress with more demand, and people of middle class and lower income, not even just the very poor, are going to have to be coming to them for services to fill in the gaps that'll be left as healthcare gets less funding.
Don, just to piggyback on that, if our listeners have philanthropic capacity, I do think community-based healthcare and support services and systems are going to be a really, really important place to focus those resources, at least in the foreseeable future.
100%, Terry, I agree with you. And don't just think about direct healthcare delivery. Think about the fill in the gaps organizations that deal with mental health issues, depression and food insecurity, housing insecurity. All of that is going to be stressed because other federal policies are also cutting back on those social services. If I must have to laugh, you look at the Make America Healthy agenda, supposedly it doesn't actually have the stuff that would make America healthy, like making sure that kids can have nutrition and families can have roofs over their head, and the services of recreation, mental health, environmental security are all in place. That's all being cut back, and so that people get sick.
Yeah, it's difficult to maintain optimism in the face of so many things seemingly moving, in the wrong direction. And I think some of the properly placed incentives that we had been working so hard to develop, some of them are falling by the wayside. I do try to remain optimistic. I believe politically that these pendulums swing. We probably will have to live through some pain before that happens. Don, I guess I would ask, sort of on the ground, from a patient and family standpoint, how can people best navigate these changes? You alluded to some of it earlier around, the importance of attending to our health and well-being. But as the Centers for Disease Control take some of the steps that they're taking, including around federal vaccination policies, sort of on the ground, how can we best navigate health and healthcare?
Well, some of what we said before, you're going to have to learn what voices to trust. And there are out there, the professional community, that it doesn't put on a partisan button. It's not Republican or Democrat. It's what does the truth say? And it's complicated. So trusting your doctor, trusting the professional societies that are stepping up. For example, there's now a very invaluable private sector initiative among professional societies to publish vaccine standards that actually are evidence informed, as opposed to the frankly crazy stuff that's coming out of HHS, CDC now, and RFK Jr. So find a trusted source and lean on them. That would mitigate some of the harm. And attend to your own health. Find out what are the things you can do to keep you healthy, as we said before. I think this is a time in which political activity is now a citizen's duty. Some of these damaging policies, we need a public to speak up on. And I hope we can overcome partisan assumptions here. And Chris, I know your organization's mission is to try to, what's the term you use?
Cross-partisan dialogue that helps us all find common ground. That's what we're here for. Absolutely. To find, things that we can all agree on. And I think, as you have each shared a little bit, I think in most cases, those at both ends of the spectrum believe in science, the science that has made our society possible and has allowed us to have the standards that we do. And so that's hopefully what we're aiming to find here.
Yeah, measles virus doesn't check what party you're enrolled in before it decides whether to infect you. A hungry child doesn't check their party in order to see how they find food. And when you have your heart attack or break your arm and you go to the emergency room, they're not going to check whether you're Republican or Democrat. They're going to deal with the budget they have. So we are in this together. You may differ depending on your partisan alignment, exactly what you think the full role of government ought to be. I believe that health is a human right and you need government to help support human rights. You may have a different point of view, but we're now at a point, I think, beyond partisanship in which citizenship means protecting yourself and your community, and that is not should not be a partisan issue. It's become politicized because of the rhetoric we're hearing from leaders who aren't, I think, somehow check their mission at the door, maybe. But no, I think we have to come together and protect our health, and we know how to do that. We have science to do that and protect our healthcare system, and we know how to do that too. Neither of those is currently consistent with federal policy. On the contrary, so stepping up as a citizen in support of each other, if that's not too high-minded, I think that's the way we have to begin to think.
Yeah, and I think there are some conditions that made it possible for some of this to take hold. I think as care has become in some respects more transactional in the past decade or two, and patients don't have as strong a trusting relationship with their primary or specialty care providers, I think they become more susceptible to suggestion from a variety of sources, essentially. And so that's, I think, part of the solution as well, as we navigate through all of this, is find people we can trust and that will be more likely to be guided by science if that's the case.
Yeah, there is a kind of a rabbit hole here I want to go into for a second, and that has to do with science itself. It's important to have a scientifically literate public, so you kind of make the best choices for yourself and the best choices for policy. And please understand, science is not like a set of facts chiseled into rock and unchanging. Science by its nature changes. That's the whole point. When we think right now that this is the right way to treat this disease, but we constantly inquiring and supporting a research effort that may discover, oh, wait a minute, that turns out not to be the best way to do it. Now we know this that we didn't know before. In a way, science is a journey constantly trying to find out where we're wrong and need to make corrections. That's the whole point of science. So those who seem, for reasons that I just don't understand, committed to tearing down our scientific infrastructure, cutting NIH budgets, ending crucial experimentation on cancer and heart disease and environmental threats, those who would take away our databases upon which we plan our public health responses. I don't know why they're doing it, but they're using a trick. They're telling you, oh, first we said masks didn't work, then we said they did work, then they say they didn't work. These scientists, they don't know what they're doing. That's not true. These scientists are on a journey for you to figure out what works and what doesn't. And so you want science to be changing as it goes. That's healthy science. It's not a flaw in the scientific enterprise. So yes, seek the best advice you can get from people you really trust who are doing the science. And then when they begin to say, wait a minute, this is even better than that, don't accuse them of having been irresponsible. They are being responsible agents of the growth of knowledge. That I know that may sound a little wonky, but it's really important in the public understanding.
And Don, I would just underline that. I mean, I think a lot of our best healthcare is built on a context of continuous learning. Right. And I think the pandemic was a perfect example. We were faced with a disease type and norms for care that we were not familiar with, and so we really had to. Our clinicians and our scientists had to learn their way into and through that. And to see that fall by the wayside or dismissed is doubly concerning.
Yeah, let me double underline that, Terry. I think it was one of the most majestic times for clinical work and science in my life, in exactly the way you said. Our physicians, our nurses, our hospital leaders, they became avid for information. They wanted to know everything they could. We didn't know when it started, for example, that when a patient with COVID is on a respirator, they should be on their stomach.
Absolutely.
That's a little unusual. And when, most patients on respirators are on their backs, but then we learned together that if you turn them over and they're on their stomach, they do better. We didn't know that at the start. We learned it as we went. One of the stories I heard early in the pandemic, as you know, the pandemic, I think, first hit our shores in Seattle, the Northwest. And within days, the intensive care doctors on their own in Seattle were on the phone to intensive care doctors in Wuhan, China, where the virus came from, to say, what have you learned? What do you know that we don't know about the management of this disease? And they shared. That was professionalism at its highest. Our journals, which had had cycle times for publication of months, suddenly it was days. They committed to much faster digestion and publication. We rose to that occasion, and I'm
Absolutely.
not sure that story is well known to the public, but it was our clinicians at their best.
Couldn't agree more.
Yeah. Now, Don, looking ahead to elections that'll come up in the next 12 months or so, and as patients, family, and healthcare professionals consider candidates that might be running for office in 2026, what kind of healthcare policy positions should we be thinking about and advocating for? Are all of these changes a foregone conclusion and we just have to get used to them, or is it possible that they could be modified depending on next year's elections?
Definitely can be modified. First, it's a moving target. The Trump administration manages to do more ongoing damage as time passes, and that's not going to stop until Congress puts their foot down and says that's enough. You can't do that anymore. This, of course, applies to foreign policy as much as domestic, but while we're talking about healthcare, the White House and the administration needs a strong signal from the public that, no, you can't destroy CDC, you can't destroy NIH, you can't take the supports away from our physicians and nurses. We need them. You can't cause hospitals to close. We need them too. And that signal can only come in the ballot box now. And I think that the administration won't immediately say yes, sir, to a public that becomes activated on this, but they certainly will be listening. And so we need to elect a Congress that is going to be not beholden to an administration that appears to do almost anything it wants. I believe that's true in the international arena as well. What's going on in Venezuela, for example, and the way we're killing people without proper procedure or legal support, that's got to stop too. But in the healthcare, the voters can speak. Elect candidates who are willing to say that they believe in science, that they want to support science, they want to support clinicians and clinical decision making, and that they want healthcare coverage to be increased in this country, not decreased, because that's what you want. So I think listen for those policy decisions and lean in on these midterm elections. I personally believe it would help if we had more physicians in Congress. Right now, the physicians and nurses in Congress tend to be a little bit more conservative than I think is helpful right now. They're not speaking on behalf of their own professions, but there are people running for office now in many states. Dr. Thomas Fisher, Tina Shaw in New Jersey, and others. So look for candidates who are clinically minded and clinically trained. That will also help get common sense back into healthcare decision making. Please, we need a Congress that will support Medicaid. Medicaid is not just a program for the poorest people around, although they are our neighbors and deserve support. Many, many, many families in this country in the middle class depend on Medicaid, and Medicaid is the most important source of funding for nursing homes, which you or someone you know is going to need. So we need to get Medicaid back in the center of the policy debate and say it's too important a program to cut. And I have a personal thing about CDC. I think it was a global treasure. It's going to take a long time to recover, even from the damage that's been done now. But we need candidates that support CDC. And on the international front, among the most horrendous policies was the cut of USAID, our foreign aid program, especially around HIV, tuberculosis, and malaria, was crucial, absolutely life-saving in countries that want to be autonomous, want to be able to do their own thing, but they need our help to get there. And we cut the rug out from under them with, I think it's literally millions of people's lives now at risk. We need candidates who are willing to stand up and say, no, that's not us.
Yeah. And I would like to think that healthcare, as it has historically been, is a bipartisan, not a conservative or a liberal issue, something that we can all agree on. I'd love to see that be the case, driven by science going forward.
Absolutely. That's been the case really until relatively recently. We had great examples of people from both sides of the aisle in the Senate and the House working together to make things happen. that are productive. In fact, some of the senators that became the most difficult to deal with prior to that were leaders on child health and prevention policy and nutrition support. I don't know where they went, but no, we have a strong history of bipartisanship to fall back on. Medicine doesn't look at your voter registration card. We're all vulnerable.
So let's take some questions from listeners now. I did receive this one in advance from Harris Contos. He asked, how do we move from procedure and reimbursement maximizing incentives to population health outcomes in a future healthcare system? Any thoughts on that?
Sure. It's a great question. And let me unpack it a bit. So what the Trump administration is doing now is extremely harmful to health and the healthcare system at large. But if Trump had never been elected and we just had business as usual, the healthcare system would still be in trouble. It costs too much. We have reports, highly reliable reports, showing that it underperforms countries spending half as much on healthcare. So there's something wrong about the way the healthcare system has been set up, and we're paying a high price for that. And we're not getting value. Our life expectancy before Trump was 4 or 5 years less than average in European democracies. Our kids are among the least healthy in the world, at the bottom of 18 wealthy countries in recent report out of the Children's Hospital of Philadelphia. So we got a lot of repair work to do. My career has been spent on quality improvement, trying to improve with leaders like Terry, the improvement of care. We need to get back to that agenda. Now, part of it is cost. Why are we spending twice as much money as any other country and getting less for it? It's because we're not putting the money where the money is needed. And that's partly supported by the payment system, as the questioner asked. It's not like hospital leaders or doctors are going in, as evil people to get as much money as they can, no matter what the effect on patients. But they really believe in what they do, and that has led to overuse of procedures, overuse of tests, overuse of bed days, and that's going to continue so long as the payment system works on a fee for service. Everything you do, you get paid for basis. A much smarter system, I think, consolidates payments. So a leader like Terry has a population to help, has a budget to take care of a population as wisely as he can. And I think freeing ourselves from the trap of the fee for service payment system. Right now, the lingo is value-based payment, and I'll show my cards. I don't really know quite what that means. I think it's lost its meaning a little bit. But what I want is to get a good healthcare leader like Terry in league with his clinicians, with a budget to take care of a population, and then do their very best for that population without having to worry that they have to keep running the MRI machine in order to keep the doors open. That's not right. So the question is right. I think en route to a better system is a payment system more supportive of what we know keeps people healthy. Now that leads to another topic, which is stuff that affects health outside healthcare. The journey of health, we know what makes, if there are two cities that differ in health, or two nations, or even two parts of your city, we know why. Here's the why. It'll be differences in the way early childhood is dealt with. Strong early childhood supports produce better health for populations. It has to do with the education system, very powerful determinant of health. Is everyone getting access to the best education that can be gotten for them? It has to do with the conditions in the workplace, generous minimum wage policies, protections for workers. It has to do with elder care. Do older people get protected against loneliness and isolation? And it has to do with community infrastructures like we've talked about: food security, housing security, clean air, recreational opportunities, a restorative criminal justice system. These are the things that make us healthy. And so we should be investing them. But as long as we're spending twice as much as every other nation on health care, we don't have the money to invest in this other stuff. I have a challenge for maybe some courageous listeners. I just spent last week at our Institute for Healthcare Improvement annual meeting, which is a great place to be. Almost 3,000 people gathered to talk about making care better. But we also had a chance to introduce them to Michael Marmot, Sir Michael Marmot, Marmot, who is a epidemiologist in England and probably the leading thinker about health. He wrote a book called The Health Gap. And I'd urge you for Christmas, get on Amazon, buy the book called The Health Gap, read it, and then ask about your community. How could this happen? Professor Marmot is interested in the United States in helping develop what I call Marmot communities. These would be cities that commit to using the knowledge that Michael summarizes in the book, The Health Gap, and actually translate it into policy. And he has a framework. It's an 8-part framework. If you want to make your city the healthiest in the nation, here's what to do. So I'm interested in seeing maybe a few dozen Marmot communities develop in the United States. I'll help. Michael Marmot will help, and you can get your way out of this hole by being healthier instead of needing to use the hospital or the expensive tests. So that's a
Very interesting. Very interesting.
Yeah.
Hey, we've just getting back to the governance side of things. We've got a question from John Winkleman that I find interesting. He says the House is likely to pass a Republican healthcare bill on Wednesday. Can you talk about the pros and cons of this legislation? Is this the high deductible plans that we've heard about, or I'm not familiar with that? Can you shed more on it?
I haven't checked the paper this morning, so I don't know. The talk from some of the leaders in Congress has been about health savings accounts, developing tax privilege ways for you to put savings into an account that you then draw down for health, HSAs. I'm extremely skeptical of this for at least 2 or 3 reasons. One is that who has the money to put into their HSA? Wealthier people. So since illness is associated with low income, we're putting the money, we're offering an opportunity for people to have tax-free contributions who don't be able to make those contributions. Second, the amount of money that will be put into the HSAs is tiny compared to the needs you're going to have if you need a hip replacement or your heart attack treated. It'll be at best a few thousand when you're going to need tens of thousands or hundreds of thousands of dollars to pay for your care. So it's not a solution at all. So it's regressive, more favorable for rich people and poorer people, and it won't be enough. I think it's going to be a Band-Aid. So if that's the bill that your question is talking about, no. Are also a threat. I mean, one way to reduce premiums is not to offer care. And so, yeah, you'll be able to get a junk plan that just doesn't cover enough, but that's a deception.
$1,500 in a health savings account for someone doesn't even begin to touch the situation when their premiums have tripled and they can't afford them in the first place. And so that's the nonsensical aspect, in my opinion, to what's being contemplated.
Yeah. I think it's just a showpiece and not real.
Okay. Here's a comment that I find compelling. It's from anonymous attendee. In the pediatric world of specialty care, I believe that for the first time in 30 years I've been in this line of work, we will need to make difficult decisions regarding those with low or no insurance, as everything else will be so much tighter. So here's someone talking about, how are they going to handle someone who comes in with low or no insurance, and can their practice afford to serve them? And that's a decision that no one wants to have to make.
No, that people fear rationing. That's rationing. That's rationing. It's not rationing care to people. It's rationing people to care. And I think it's cruel. It puts you in a terrible position. Talk about moral injury. A doctor who would be forced to turn someone away would be a doctor who knows they're not doing what they took an oath to do, but they can't make magic. So I think the listener's exactly right. We need to support clinicians, not make it impossible for them to give the care they took an oath to give.
I'm going to sneak in one more question here from Tricia Chea. She says, can you speak to the Medicaid 1115 waivers, particularly how the health-related social needs components were recently taken out of the RI waiver? How does the current administrative plan evaluate these waivers on a case-by-case basis? Is that familiar to you?
Sure. Well, the waiver program, there's one in Medicare, there's one in Medicaid, allows a state to come forward and say, we want to try this new way to give care, as we've been talking about. We think it can produce better outcomes at lower cost, or at least at the same cost, or the same outcomes at lower cost. And so there's legislation from the origins of Medicare and Medicaid to give states a chance to try out something new. And the 1115 waiver is one form of that. So what would happen is a state, let's say, would apply to Medicare and say, we want to try this new way to deal with this condition or with the new payment scheme. Do we have your permission to do it? And that gets reviewed. And then if the powers that be, like the OMB, the Office of Management and Budget, or the actuaries in Medicare say, okay, that won't cause, that makes sense. We won't break the bank if we try that, then they can go ahead and try it. And a lot of creative stuff has gone on under the waiver provisions. Now, and one of the most creative under the Biden administration was to allow those who applied a chance to pay for stuff that doesn't sound at first like medical care, but it actually would have a strong effect on utilization. I told you some of the things like early childhood supports or education programs or workplace supports or so-called social determinants of health like food or housing or transportation. And so, yeah, Medicare began to allow experiments with broadening coverage to include these they're not pills and they're not operations, they're just other health determining features. Now the government is backpedaling on that to some extent, taking away the permission to try these things out, which is sort of closing our eyes to some really interesting things that could be happening. The rationale has been that, well, states abuse waivers. They're actually, it's just another way to get more money. And to be clear, that is sometimes the case. That's why you need a vigorous and capable administration in CMS to tell the difference between a waiver that actually could do some good and one that's just another way to get more money.
Yeah, we're just about out of time. So Don, I want to ask, do you have any closing thoughts of hope or inspiration for our listeners as we kind of navigate, hopefully, towards a better system? Anything that you would, leave us with at the end of this conversation?
Yeah, well, 3 or 4 things. First, understand the dedication of our clinical workforce that really is there. They're not saints. They're normal people, but like normal people, they want to help. So your doctor, your nurse, your clinician, and your hospital manager, they're still there to try to help. And that's got to be a deep strength in our system. And you can see it when people are together, especially at the community level, to try to do the right thing under this tremendous pressure. So that gives me tremendous optimism. I think youth also does. I think the young in our healthcare system are even more alert and aware and are not going to put up with the nonsense. I think another thing that's sort of bad news that becomes good news is this thing has been broken so badly by the current administration. As you watch these premiums go up, you watch doctors and nurses become demoralized, the key research programs cut off, so cancer patients lose the chance to participate in helpful research. Sooner or later, I think this is going to be a point where people are saying, wait a minute, this is not what I want. And even those who may have supported this administration may begin to say, no, this isn't what I voted for. So I think, I really do believe we're reaching a tipping point here where the public concern about the damage is going to outrun the rate at which this damage is being done. To participants, I think this means you've got to become political. Votes are really, really going to matter to preserve the health and healthcare you want more than ever before. So you need to be the voter that says, no, I think healthcare needs to be improved, not destroyed.
Yeah. Now, Terry, you have been one of those that lived this in your work at Cone Health. Anything you would add to that or share from the perspective of a healthcare professional?
Hard to improve on Don's comments. I would just add that, to his point, our clinicians and provider organizations around the country are deeply committed to helping people. It's in spite of some of the rhetoric out there, you've got people who went into this work because they wanted to make a difference in the lives of others. And I think in the final analysis, that's what's going to hold sway. That is consistent. It's in place now. And now we just need to bring back rationality to a system that hopefully would move away from paying for volume and instead as Don said, really incentivizing and paying for us to keep people well and healthy and out of the hospital. And the really elegant thing about that is the right thing to do, ethically, morally, and otherwise, is also far and away the most cost-effective thing to do.
You bet. If I could take a minute building that, as you know, Chris, I have a podcast with my colleague Kate Armonte called Turn on the Lights. It's available wherever you get your podcasts. And Turn on the Lights is dedicated to revealing some of the nonsense that's going on and the bad stuff, but also many of our shows are about really wonderful things that are going on despite everything else, programs, projects, efforts that everyone ought to know about because they give you some hope. So I invite your listeners to get involved in that podcast series, which is designed to reach the general public, not just clinicians.
Well, that's a great advice, and we'll definitely be checking that out. My only remaining thought, building on what each of you said, and I'm not the healthcare expert that each of you are, but I do know a lot about human behavior, and I know that we need to take care of one another. And I think as we navigate through this, as we have through other challenges in our society, we need to make taking care of one another our priority, and everything else works a lot better when we're focused on that rather than win, lose, or politics, or left, right, or what have you. So I'll just close it there. So Don, thank you so much for such an insightful and thought-provoking conversation. It's been a real pleasure talking with you. Terry, thank you for joining us as well. I'd like to thank you, our listeners, for your time and your thoughtful questions. And so be sure to join us for another episode of the Unity Forum. We'll be exploring more thought-provoking insights and issues with well-established experts. Until then, have a great day and a happy holiday season. Thank you all. Take care.
Thanks for listening today. If you enjoyed this episode of the Unity Forum, please give it a rating, share it with others, and join us on Facebook at Alumni for Freedom and Democracy. And be sure to join us next time for another thought-provoking discussion on the big ideas shaping our collective future.